Good evening, everyone, and welcome to our Shoulders and Hands update. My name is Helene, and I'm the Workforce Development Officer here at Westvic PHN. And working alongside me is Jade, who is also a Workforce Development Officer. I'd like to begin by acknowledging the traditional owners and custodians of the unceded lands and waterways. I'm dialing in from Wadawurrung country today. We recognise their diversity, resilience and the ongoing place the First Peoples hold in our communities. We pay our respects to the elders, both past and present, and commit to working together in the spirit and mutual understanding, respect and reconciliation. We support self-determination for First Nations peoples and organisations. Just a little bit of housekeeping before we start. You can view the majority of our webinars recordings. They're available on our PHN Learn YouTube channel, and that's they're free. You don't no cost for those. We will put the link on the access our recorded webinar events into the chat. Please see our upcoming events on the screen now. You can register for these events on our website. We will put the link in the chat for you also there. Just take a note of the Westvic PHN health pathways relating to this topic, and that's on the screen at the moment. If you have ended the webinar not displaying your accurate first and last name, could you just type your full name into the chat box? This is only admin will see it, and this is just to ensure that we get your correct name for your certificate of attendance. For this evening's webinar, all participants will remain on mute. If you have any questions, just type them in the question and answer box, and I will address them throughout the webinar. It's all anonymous, so your names won't be read out. Your feedback's important, so if you could take the time to complete the event survey after the webinar, and there'll be a link in the chat box to complete this. I'll give you a reminder after the event. So for this evening, our presenters are Associate Professor Kevin Eng, who's an orthopaedic surgeon, Emily McMaster, occupational therapist, accredited hand therapist, and Jane Skeen, occupational therapist and accredited hand therapist. I'll just hand over to Kevin. Thanks, Kevin. We'll commence now.
No worries. Thanks, everybody. I'll just put my share screen on and looks like that's going to work well. Helene, can you give me the thumbs up if that's okay? Yep, great. Well, thanks everybody. So I'll quickly run through just some short, punchy up-to-date or updates on some shoulders and hand things. We'll look at replacement, instability, and rotator cuff, the three common things in shoulders. And for hands, we'll look at carpal tunnel, wrist fractures, scaphoid, and some arthritis. But for shoulders and hands, MIT are currently working on accessory arms and shoulders, but until we get those more widely, surgery is helpful, but early therapy is extremely important, both for prehab and post-surgery support. If we go to shoulders, the first thing we'll talk about is arthroplasty. As I'm sure you all know, there are two broad modules. They can be anatomic, where the ball is replaced with a metallic ball and a plastic socket, or they can be reversed, where the ball is replaced by a plastic socket and the socket is then screwed on to where the glenoid used to be. These have been around for a long time, but just to update you that now our stems, particularly in the anatomic side or construct, are virtually becoming very stubby, and we call those a stemless shoulder replacement. They've got quite good runs on the board, relatively low revision rates, and they allow us to more accurately reproduce the ball shape of the head, and they take out less of the bone than a standard large stem. So they're actually a bit less painful for the patients in the immediate post-op period. We've been working with companies and utilizing various models of computerized planning. So the patients now have a CT as a routine, and we do virtual implantation of our implants. We can size them and measure all the angles that we need to get right. custom guides are then printed out and shipped into surgery, and they're specifically made for that patient, so you can get the components exactly where you want them to be. Navigation and augmented reality has been difficult in shoulders, but is now available for use, and robotic assisted surgery is also being developed in parallel. We expect the first robotic things to come out in the States probably in the next 12 to 24 months, but we'll let them do a lot of the early testing, shall we say. In terms of dislocating shoulders, the classic one, particularly in football and netball season, is the athlete who's had some sort of collision. We'll talk about that group. Certainly there's good studies to show that even at 10 years, if you have a stabilization procedure, your risk of redislocation is around 10%. But if you don't have a stabilization procedure, your risk of redislocation is 50 to 60%. So surgery does change the natural history here. So early orthopedic review is very worthwhile, and we're very keen to avoid the scenario where patients might have their shoulder reduced in ED and then not be assessed and then have 3, 4, 5 subsequent dislocations. So the aim of the surgery in younger patients is to prevent recurrence, like poor old Gary here. But even if we have middle-aged or older patients who dislocate their shoulders, they have a different set of pathologies, but need early review to exclude pathologies such as massive cuff tears that can happen when you're older and dislocate your shoulder. And we're happy to see those too. Over the last couple of years, we're doing more and more what we call remplissage. So when the shoulder dislocates anteriorly, like most athletes would have, they might have a Bankart lesion here and a dint in the back of the humeral head. And this procedure has been around for a long time, but it's becoming more and more commonly used, and I did one today. And the reason for that is that there's now been one randomized controlled trial and several cohort studies showing that if you do a remplissage, your survivorship is much higher than if you don't have a remplissage. So particularly using that more and more to try and reduce the risk of recurrence. In terms of bone grafting for shoulders, we classically do what's called a Latarjet procedure, where we take some of the coracoid and screw it into the front of the glenoid or socket to try and deepen the socket if there's been bone loss. But nowadays we can do that arthroscopically through small cuts. There are various techniques described, but ultimately this means you can align the bone graft very flush with the native surface and rebuild that surface with much more accuracy and lower morbidity to the patient. We've got a series of about 10 or 11 of these so far, and they're doing quite well. But whatever the shoulder problem is, we're happy to sort out the pathology and give the patients up-to-date information. But if you do see these patients, don't hesitate to send them to us early. We do see a group of them that recur, and we do see a group of older patients that really struggle along with axillary nerve palsies or rotator cuff tears. And intervening earlier in that group is probably better. Rotator cuff remains an extremely common presentation. As people know, there are 4 tendons in the rotator cuff. The subscapularis is a big, powerful one at the front. The infraspinatus is a big, powerful one at the back. And the supraspinatus is a moderately powerful one at the top. But we treat cuff tears in each of these areas slightly differently. And there are various flavors of cuff tears that happen. So we don't think of them as one conglomerate or one group. If you've got a patient where you suspect a rotator cuff pathology, an ultrasound and an X-ray is a standard investigation still. The X-ray is very useful for looking for arthritis or calcific tendonitis, or heaven forbid, infiltrative malignancy, which I have seen 2 cases of, which is always difficult news to break to the patient. The ultrasound is a dynamic screening test for example, a supraspinatus tear or a subscapularis tear. And once we see a patient like that, as surgeons, we like to do an MRI after we've seen the patient, because it gives us information confirming the diagnosis, but also gives us what the likely chance of successful surgery is. And the Koreans have published this rotator cuff healing index, which is very helpful. You can show the patient some of the factors that go for or against surgery. And basically, they allocated points to each of these factors, but you can see a large number of them are dependent on the MRI findings. So the tear size, retraction, the fatty infiltration are all dependent and can only be seen on the MRI. And basically, the higher your score was, the lower your chances of healing when they went back and looked at their cohorts. And this is really useful information to give both for surgery, but also to the patient, so they understand that they're not just going to have surgery and get fixed. It's a relative or probability type calculation for them. This probably still remains the best randomized controlled trial for small size supraspinatus tears, which are the most common rotator cuff tears that we would see. And they followed their patients for 10 years. And early on, in the first 2 and 5 years, there wasn't much difference between the groups that had surgery and didn't. But over 10 years, they had improved strength in the surgery group, increased flexion, and less pain. However, it's not a huge difference. So if your patient's got a limited level of activity, or is going to have maybe less than 10 years of working life or lifespan, it's worth having a discussion with them. Just to let you know, we've also started a shoulder registry in our rooms. Professor Page and I are capturing a lot of our outcomes related to PROMs and surgery for our rotator cuff and instability cohorts. And we've got 2 to 3 years worth of data now, and that continues to grow. But Prof Page and I are planning on giving a shoulder update probably in the first half of 2025, to which you're all most welcome. If we move on to hand, it's not particularly new, but we're doing more and more what we call wide awake local anesthetic no tourniquet surgery. And carpal tunnel is the classic for this. So this is a lady who I operated on, and this is her wounds 2 weeks later. She's had a carpal tunnel and a Guillon's canal release. But she was a heavy smoker, had airways disease, but burning pain in her hands. And so she doesn't have to have a general anesthetic. The local anesthetic now includes adrenaline, so there's less bleeding. She was on aspirin. And we don't use a tourniquet, so it's much easier for the patient to tolerate. And this surgery has been around probably for 15 years, really championed by a Canadian specialist, but it allows surgery to be done in more ambulatory centres or in centres with fewer resources, but has really sped up the recovery. So the next day, the patient just takes their bandages off and washes their hands, and generally their wounds heal quite well, even in patients who aren't particularly healthy necessarily. In terms of carpal tunnel, a question I got asked was, what is the role of nerve conduction studies? When should we order them? I take a fairly practical approach. If I'm clinically happy that the patient has carpal tunnel syndrome and there's nothing particularly concerning, then I won't order a nerve conduction study and we'll proceed to appropriate treatment. But if there's something unusual or a potential medico-legal issue or a third party involved, then I will get this as evidence that there is an electrophysiological problem matching our clinical findings. Wrist fractures are always an ongoing issue, and I thought I'd give a brief update. The real question is, well, for a surgeon anyway, when do I need to operate? And if the fracture is extra-articular, well, maybe you should consider operating versus not operating. If it's intra-articular, there's evidence, very good evidence that you should consider operating strongly, and all of these patients should get hand therapy. And we were just remarking before that there is a shortage of funding in Bowen Health. So I'm the director of orthopaedic surgery there, and one of the things we instituted was, because we don't have enough hand therapists, was a cheat sheet. So everyone who goes into a cast with a wrist or hand cast or brace gets this cheat sheet, and it shows them what exercises they should be doing, even though they're in the cast. So it's not put the cast on and forget, it's put the cast on and exercise. So we get their fingers going, making a fist side to side, using your other hand to help you, and pronation and supination and dexterity exercises. So hand therapy is a must, even when you're in the cast. It should start straight away. If we look at some of the latest evidence out of the Netherlands, there have been various studies showing that if the fracture is extra-articular, so a classic Colles type fracture, that fixation here in the circle group might have a fairly equivalent outcome to no fixation. So if your fracture is extra-articular and not widely displaced, you can certainly consider treating them in a cast, and they'll have a pretty good result at 12 months. If the patient is high functioning, though, they will get a probably on average better result with surgery, but it's by no means compulsory, and it's a discussion that we have with the patient, particularly if they're older and lower demand. If the fracture is intra-articular, and you can see here several examples that extend into the articular surface, then the same group did a randomized controlled trial looking at fixation versus casting, and the fixation group here consistently had statistically better outcomes pretty much across all timeframes. And a lot of about 20% of the patients crossed over from the non-operative group. So casting is less effective for intra-articular fractures, and we would be more likely to operate on that group. Scaphoid fractures always remain a difficult diagnosis to make. I think there's two major questions with scaphoid fractures. The first one is there a fracture at all? Because frequently you can't see it on the x-ray, but you're suspicious because your patient's had a fall and has persistent wrist pain and might be tender right round the snuff box, for example. If they're clinically suspicious, we would then get an MRI. The second question is, does the fracture need surgery, or is it okay to just cast them? So this might be the group where you can see the fracture on the x-ray, but you don't know its exact morphology. In that group, we would get a CT. And Raker and Professor Page, who are two of our Bowen Health surgeons, published this paper, and it's what we use at the hospital. So if you're suspicious, but the x-ray looks fairly normal, then we go straight to an MRI. The sequence takes about 10 or 15 minutes. If there is a fracture identified, then we use a plaster or refer for surgery as appropriate. And this is the group here that we would then get a CT. If there's a soft tissue injury or nothing, then the patient doesn't actually need a splint. So if you've got access to an MRI, it can save the patient an extended time in a cast. And that means they can get back to work and back to function much more quickly. So here's an example of a patient of mine from last week. Fell over, had a painful wrist, normal x-ray. We got an MRI, and you can see the high signal here showing bone bruising in the proximal waist and pole of the scaphoid, and we treated that lady in the cast. However, this is another chap, younger, multiple footballing injuries, had pain last year, and then had a fall again in this season and had a lot more pain. An x-ray was done, and you can clearly see a fracture across the waist here. You can see this looks a little sclerotic, so it matches his story of having a fall last year. And in this case, we don't get an MRI, but we go straight to a CT, and it shows us that he's missing quite a lot of bone and got a significant humpback deformity. So we'll be operating on him in the next month or so, and hopefully he'll get a united scaphoid. If you're going to cast a scaphoid, we no longer include thumbs. So basically, thumbs down, you can just leave the thumb free. The scaphoid is not actually part of the thumb per se, it's more part of the wrist, and so a standard cast not involving the thumb is perfectly adequate. There have been multiple trials showing that there's no difference in the union rate, and in fact, I did see this study out of the States, which in fact showed more union when the thumb was free, but I suspect that that's a statistical anomaly. But ultimately, you don't need to include the thumb, and the patients tolerate these casts much better. And nowadays we have access to these waterproof fiberglass casts, which Jane and Emily do a lot of, and they are much more practical for patients, and particularly kids who want to go to swimming class, for example. Thumb CMC OA remains an extremely common problem. As you know, it affects women more than men. However, there's a few variations on a theme here. There are those that have bog standard primary OA, but there are those that have a lax thumb, and they might have earlier onset arthritis. So they might get it in their 50s, for example. They might have a dysplastic trapezium. And the thumb is designed to be an arch when you're in tip pinch. And you can see arches in nature and in bridge building are a lot more stable constructs than these collapsed Zs. So early on, and I know our therapists will probably talk about this, but I know early on, we do try to educate the patients that you want your thumb to be like the claw of a bird of prey. You don't want it to be collapsed down like a Z, and that forms a nice solid arch and can help redirect forces. So it's less painful for them. In terms of surgery, if they've got a fairly standard arthritis, if they're younger, we try to do bone preserving procedures. So in some patients, we do arthroscopic excisions. In other patients, we might put a disc. In older patients, we excise the entire arthritic trapezium and take some of the ligaments and take some of the tendons and do a ligament reconstruction. And this is a fairly tried and true method and has very predictable good results. If they're a hyperlax patient, we may need to deal with the entire thumb ray, and that can sometimes involve doing a fusion or tenodesis of the MCP joint to give the patient a more solid arch. But in all these cases, early hand therapy is really important. In carpal tunnel, I'll see them at 1 to 2 weeks post-surgery, and if they're not progressing as I expect, I get the therapist involved straight away. If they're just had surgery for a scaphoid and I cast my scaphoids for 8 weeks, they're still seeing the therapist to get in-cast exercises. So I'd really encourage people to get to a therapist early. And the OA patients can be treated in the early stages before they even get to surgery. We've already talked about the health pathways. They're certainly written by us in conjunction with many of the GPs. Feel free to access them. We just updated them last year, and I can certainly encourage you that they're reasonably accurate as I've just been over them. If you need help, I am part of Geelong Orthopaedics group in public, in private, and I'm also at the public hospital about 50-50. You can always call our sort of hotline if you want some advice, but being a surgeon, sometimes we're in the middle of consultations or something's happening, so please feel free to ring twice. And if you're looking for a surgeon, you can go to a website and click sort of expertise and sort of see what problem your patient has, and then you can click on these buttons and find which of our surgeons might be able to help you out and do an appropriate referral as required. So thanks very much. It's just a brief rundown for the first half hour. And I'll hand over to Emily McMaster, who's we work closely with, as well as Jane over at Geelong Hand Therapy Group. And we can't wait to hear what you've got to say, Em.
Thanks, Kevin. That was great. All right, I will bring up my slides. Let me click a few buttons. All right. Lovely. So I'm just going to touch on a couple of things, trying to link in a little bit with Kevin, and trying to address, I guess, some of the main issues that we're seeing. I just want to quickly talk about the hand and the shoulder relationship and the secondary complications that we tend to pick up in hands after someone has had shoulder surgery, and then occasionally vice versa, what we're seeing with the shoulder after hand surgery. And then we'll just touch just quickly on carpal tunnel and post-op therapy, just our little opinions on some things about that. So as I just said, just really want to talk about the relationship between shoulder impairment and secondary hand dysfunction, and how some early hand therapy following carpal tunnel release what we think it improves patient recovery times and minimize the risk of complications. So if we're looking at the function of the shoulder and then the function of the hand, really the function of our shoulder is to position our arm and our hand, so our hand can then do what we need it to. If we're looking at the function of our hand, the function of our hand is to grasp, to hold, to manipulate, to feel, grab objects, and then to bring them to our body or to move those objects elsewhere. So our shoulder and our hand are always working concurrently. Our shoulder positions our hand does what it needs to, our shoulder then brings and moves the hand back for our hand to do the intended purpose of the task that we're trying to do. So what we're seeing is that after injury or surgery, in shoulder impairment, what's happening is people can't position their arm for placement. So patients tend not to use their hand functionally because their shoulder is not doing what you're asking it to for them to be able to use their hand. And vice versa, if someone has a hand impairment, the patient sometimes can believe that they can't use their hand functionally to a certain degree. So that then leads them to think that there's really no need for them to position their arm because their hand serves them no purpose for that time being. And then that limits normal shoulder range of motion. So then they develop secondary shoulder stiffness, which then can lead on to a couple of other things. So in the literature, having a bit of a look at this, the complication rate for hands following shoulder surgery can be as high as 30 to 40% was what I was finding. The most complications that they're talking about are swelling, flexitinosynovitis, and carpal tunnel syndrome. So those things are kind of linking in together. If it's not addressed quickly enough, it can progress to chronic regional pain syndrome in severe cases, but we really obviously try not to let it get to that point. The average onset of complications is within the first 4 to 6 weeks post-op. So really similar to what Kevin was saying, and we're all for this, is that early therapy and getting to these patients as early as possible is key, because if we can prevent the complications from setting in to begin with, we're really saving ourselves a lot of time and a lot of recovery time for the patients as well. So the reason why we're seeing hand complications after shoulder surgery is that most of the time, necessarily after shoulder surgery, is that patients will go into their sling to restrict their shoulder. But then obviously, as you can see, the sling also restricts their elbow, their wrist, and their hand function. So similar to what Kevin was saying, is that a lot of people, you know, for example, the people with the wrist fractures who go into a cast and they think that it's time to rest, they'll do exactly the same thing when their arm is in a sling. So they'll go into the sling, they'll rest their shoulder, but then they just completely forget about their hand and their wrist and their elbow is also getting rested when it doesn't need to be. So naturally, these patients aren't using their hand functionally because it's stuck to their body, and they're lacking that need for them to use their shoulder to reach and grab. And patients are really lacking the knowledge to understand what keep on moving your hand mean. So, you know, it's really common that after someone's had a injury or surgery to their shoulder, that they're being told the right things and saying, keep moving your hand and keep things moving. But in their mind, you know, they'll come to us and say, oh, I've been doing this for 6 weeks, but I still can't move my hand. And what they're not recognizing and what they're not realizing is that that is not enough to keep full range of motion of your fingers. And then also as well, what we're seeing, or a big factor, is that a lot of people who may need shoulder surgery are part of an aging population. So if we're looking at people who have had total shoulder replacements or rotator cuff repairs, it might be more on the degenerative side because they're on the more mature side of things. And then because of that, they're a lot quicker to stiffen up. And then that's when we're seeing these complications set in. So this is what's happening for people to get these secondary hand complications. So they go into their shoulder immobilization after their surgery. They have restricted hand function. So their hand is in their sling. They're not getting that incidental daily range of motion that they would normally get. They may have poor health literacy. So as I was saying, they lack the understanding about the range of motion needs of the hand to be able to maintain their current function. So they're not going through their full range of motion, which means they then start to get adaptive shortening of their soft tissues. They get joint contractures down in the small joints of their fingers, and that all leads to stiffness. That stiffness, once that sets in, increases the work of flexion through the flexor tendons. So the flexor tendons are having to work harder to overcome the stiffness that's set in their hand. And then that increased work of flexion then causes the onset of flexor tenosynovitis. And then as people start to develop flexor tenosynovitis, that extra fluid going through the flexor tendons then puts pressure through the carpal tunnel, which then is leading to pressure on the median nerve and then causing carpal tunnel syndrome. Then because they have flexor tenosynovitis and they have secondary carpal tunnel syndrome, they are lacking their normal hand function. So then the circle goes round and round and round. And where we try and step in is in this section here. So our role is to come in and to really educate people and say, this is what we need to do. This is how much you need to be using your hand. And this is how we're preventing stiffness. So stiffness sets in after about 2 weeks of immobilization. So really quickly. And that's where that early hand therapy referral becomes really important. Our hands are differentiated to the rest of our body by the presence of long tendons and a really large number of joints. So inclusive of the CMC joints and distal to the CMC joints, there are 19 joints in the hand. And that's a lot of joints that can get contractures and start to stiffen up. There was this one study by McGone and his friends from 2021 that was looking at the complication rate of hands following shoulder surgery, but then also looking at the problems that people had with their shoulders, and then also the recovery time once they identified those problems and tried to address them. And what they found was that hand and wrist symptoms that were problematic took an average of 4 months longer than shoulder symptoms to improve. So as much as we don't want shoulder stiffness and secondary shoulder things to come in after a hand issue, hand and wrist stiffness and pain and complications can really take a long time to settle down once they've set in. So it's all about trying to prevent it from happening in the first place to help that patient have a much quicker recovery. So the role of hand therapy really is to prevent that stiffness, and we do that by managing edema and swelling in the early stages. And we really want early full mobilization of the fingers, all the digits, and the wrist. So that early treatment is key. Wrist stiffness is, again, something that we're seeing for people who have been using a sling after shoulder surgery. A lot of the time when people are in a sling, they really should be keeping their wrist in a neutral position. But sometimes what we're seeing is that patients are more comfortably pronating their wrist and resting in a pronated position for the duration while they're in their sling. And sometimes I will say that is because they're trying to do a little bit of hand function. So they're pronating their wrist to try and use their hand a little bit more functionally, but then forgetting to get their wrist back into that neutral position. So if we just quickly look down at the distal radio-ulnar joint, when our wrist is in a neutral position, the radio-ulnar ligaments on the dorsal and the volar sides of the wrist are in a nice balanced position. And as soon as we pronate and supinate, the dorsal and the volar components shorten and lengthen depending on which way you're going. So if someone is sitting in a pronated position for 6 to 8 weeks, just from resting in a sling, some of those ligaments are going to shorten, they contract, and then all of a sudden someone will have starting to develop a pronation contracture and then are unable to supinate. This can then lead on to things like ulnar-sided wrist pain and generalized stiffness as well, sort of contributing to flexion and extension of their wrist. So again, what we are just trying to promote and trying to encourage our patients to do is to complete full mobilization of all of their unaffected joints, so their fingers, their wrist, their thumb, really to prevent that stiffness and then the secondary complications that come from that. Ideally, we want the elbow to be included in that mobilization as well. If it's safe to do for the shoulder, we can help our patients find ways to stabilize their shoulder to be able to complete their elbow range of motion. We do see, and this was mentioned in the literature, that sometimes people are developing secondary cubital tunnel syndrome from prolonged flexion of their elbow and the pressure that's causing on their ulnar nerve through the cubital tunnel. It's not as prominent of an issue as what we're seeing with flexor tenosynovitis and stiffness in the fingers, but just something to be aware of. So if we look vice versa, when someone has a hand injury, we then sometimes do see that they develop some secondary stiffness of their shoulder. And the reasoning behind that is because sometimes there's this perceived understanding from the patients that they can't use their hand at all after surgery or an injury. So if this perception continues, you know, that perceived lack of function that they have of their hand impacts on their shoulder because they're not reaching, they're not grabbing, they're not using their hand for that daily function. And that increases their risk of stiffness, frozen shoulder, weakness, bursitis, all the rest of it that comes with not using things as they normally should be. So this other study from 2018 found that up to 35% of patients in their study experienced shoulder pain during and after wrist immobilization. And the biggest predictor of them developing shoulder pain, which was mainly in their study due to stiffness, was wrist immobilization for greater than 3.5 weeks. So again, everything's, you know, contributing and emphasizing the need for early input and early education to our patients to make sure that they're moving everything and not keeping things still that don't need to be kept still. Just on that perceived notion of not being able to use your hand after an injury, it's actually really rare with our hand injuries that someone can't use their hand at all. So one of the only things we can really think of is something like a flexor tendon repair is a post-operative condition that we are telling people, no, you can't use your hand for function because of the risk of rupture and the connection of all the flexor tendons together. But other than that, injuries and surgery is really isolated to a particular location of the hand. And there is still the capability of the rest of the hand to have some kind of function. So our job is really educating people and promoting the hand to still be used for light activities of daily living, but just avoiding unnecessary loading and unsafe postures. So our role, as I said, is really about early intervention and mobilization, and it's to prevent stiffness. With shoulder injuries and surgery, we're always ensuring patients, or when we get them, we're promoting patients to be completing full range of motion through their fingers, their thumb, their wrist, to prevent that stiffness and the secondary flexor tenosynovitis, which can then lead on to carpal tunnel syndrome. With hand injuries, we're always telling our patients from our first appointment with them that they need to be maintaining their shoulder and their elbow range of motion. We're encouraging those light functional activities to get that incidental daily range of motion so that they don't have to focus and sit there on their dedicated home exercise program as much as what they would need to otherwise. We're educating our patients about typical healing timeframes so that they have realistic expectations, maintaining safe function during their recovery period, and really avoiding prolonged immobilization of any joint that isn't injured. So just want to touch base quickly on carpal tunnel release. We're big promoters of post-operative hand therapy. We know that, so touching on carpal tunnel release, we know it's release of the flexor retinaculum to remove pressure on the median nerve. It is viewed as a straightforward procedure, and I have this in a little question mark. I do think it is correctly perceived as a straightforward procedure when it's done by a hand surgeon, and I think sometimes it can get a little bit complicated because patients can overly think that it's a straightforward procedure and sometimes take things a little bit too far, or there are other contributing factors that then may not necessarily make it as straightforward a procedure as someone else. So it can get a little bit complicated, I think, depending on the patient factors sometimes. The need for post-operative hand therapy is strongly debated in the literature. So if you do a literature search, you'll easily find literature supporting no hand therapy post-op, but then also literature supporting therapy. And I think it's dependent on the author of the literature. Our view, obviously, as hand therapists, is that we really view post-operative hand therapy as beneficial. And we see in practice that if sometimes things are not going to plan, it's harder for us to come in on the back foot and try and help complications than what it is to prevent them from happening in the first place. So what we're seeing with carpal tunnel releases, if they're being referred to us with a delayed referral, and what I mean by delayed is longer than 4 weeks. What we're commonly seeing if someone hasn't been referred to us immediately after surgery, but they then get a delayed referral, is it's usually coming sort of 6 to 8 weeks post-op when they've had quite a few months, things are not settling down, and then it's being recognized that things are not going to plan. So then we get them around about that 6 to 8 week mark. But from a delayed perspective, I would probably classify it as anything greater than 4 weeks. What we're seeing with patients who are coming to us then is that they're presenting with stiffness, they're presenting with pain at their carpal tunnel in their palm region, at the base of their thumb, their hypothenas, with that sort of typical pillar pain region. They might have an ongoing sensory deficit, or they're lacking strength. They're the main 4 reasons why people are coming to us. If we look at each of those 4 things, we can figure out why those are happening. So with stiffness, sometimes with these carpal tunnel releases, again, it's in an aging population. They might have been lacking the necessary mobilization requirements to keep up with their finger range of motion. They're quick to stiffen. That risk of flexor tenosynovitis kicks in again. If we look at pain, so that pain in their carpal tunnel, at the base of their thumb, what is a common thing to see is an irritation of the first CMC joint. So the flexor retinaculum attaches at the first CMC joint. So if they have pre-existing base of thumb OA, that release of the flexor retinaculum can really irritate that and flare that up, as well as some excessive scar tissue development right over the carpal tunnel is the biggest cause of pain in that region. We might see an ongoing sensory deficit, and usually that's dependent on the pre-op nerve compression severity and a lack of strength. So with that, it's usually because patients are unsure when they're meant to start forcefully gripping again. They're not sure when to do things or how long to hold off, or possibly they've even gone back and done things too quickly. The thing about all of this is that most of these are preventable if we catch them early. The ongoing sensory deficit is slightly different, but what we can do if we catch people early is we can manage their expectations depending on what their pre-op severity was. But everything else we can actually prevent from happening if we get that early referral. So again, the reasons why we're seeing this, it's really a lack of education and understanding on the patient's behalf. So with the flexor retinaculum healing time frame, it's a soft tissue. It's going to take 6 weeks to heal. Very normal for people to still be a little bit tender over that palm for that first 6 weeks. The scar tissue formation and the location of it, patients don't realize how much scar they develop over that flexor retinaculum as it's healing, and they don't understand why they get a lump in their palm, and that can be quite confusing for them, which then impacts on their function. That pre-op severity of the median nerve compression, if someone's only had a very mild compression, they may get that instantaneous improvement, but a severe compression that has had flattening of the median nerve and already has wasting of the thenar eminence, they're not going to have that instantaneous improvement. And sometimes we need to help manage some expectations around that. And a lack of understanding, again, about how much they can mobilize, when to mobilize, the correct amount of mobilization. And as well, there's always this informal discussion with patients that they have with their family and their friends, because someone knows someone who's had a carpal tunnel release and they recovered in this way, and then their friend didn't recover at all, or it took 12 months. And because there are just so many patient factors that impact on how someone's going to heal, patients are chatting amongst themselves and not really getting a good expectation for their own self and what their healing timeframes would be. So when we're catching people with post-op carpal tunnel release therapy, where our therapy includes education, so it's all around that healing timeframes, managing their expectations depending on their severity of what their carpal tunnel syndrome was before surgery. We're doing mobilization, we're getting those tendons gliding, we're preventing stiffness and that risk of flexor tenosynovitis. We're working really strongly on scar management, so trying to soften that scar tissue development over the carpal tunnel so they don't have that big lumpy feeling in their palm. We do sensory re-education, sensory retraining when needed. We're doing strengthening, so just generalized strengthening when the time is right, and sometimes we can do some specific thenar strengthening if they've had some wasting in the past and they're starting to get some re-innervation of those thenars. And we can splint if needed, so it's not always typical for someone to need to be splinted after a carpal tunnel release, but sometimes there might be an occasion where it's called for. So for example, if there was a young mum who had pregnancy-related carpal tunnel syndrome that didn't go away after she gave birth, so she ended up going on to have a carpal tunnel release, but she still has lots of young children at home, she might be someone that we would put a splint on just to give her an extra level of protection while she has a higher functional demand as she's healing, versus middle-aged to an older person who has the luxury of being able to rest and avoid some of that forceful gripping that we suggest they do for the first 6 weeks. So from our experience, post-op carpal tunnel release therapy can improve healing timeframes by preventing complications. So it's all about that early referral, the early intervention. We educate patients, we manage their expectations, but we also promote the confidence to let them know what they can do, how to do it safely, but then what not to do. We can address other comorbidities that may influence their recovery. So if their first CMC joint has been irritated, and they may only need one therapy appointment with us, and that's all they need. We can give them all that education, and they may not need anything further. So again, while surgery may be simple and the recovery very well may be simple for lots of people, sometimes it's not, just depending on those patient factors. In practice, what we find is that patients who do have immediate or early hand therapy sort of within the first 2 weeks rarely have post-op complications. And on average, we would only see those patients once, maybe twice. However, the patients that we're seeing via a delayed referral, those complications have already set in, which is the reason for the referral to us in the first place. And those patients on average, we're seeing about 3 or 5 times to try and get on top of everything. So we do find that early referral does tend to make quite a big difference. And that's it for me. So I did a bit of talking. I'll hand over to Jane, and she's going to touch on basic thumb OA quickly.
Thank you very much, Emily and Kevin. So let me just, multiple sharing. Allow multiple sharing.
Sorry, there we go.
Okay.
I was a bit delayed with mine.
You're okay. And hi, presenter view. Sorry, hang on a minute. Okay, so I'm going to be just talking about first CMC joint osteoarthritis, a favourite topic of mine. I actually really enjoy working with this client group. I feel like we have a real role to play in helping people who have got first CMC joint arthritis. So as Kevin said, a very common condition seen in hand therapy clinics everywhere, I imagine. It's often not considered a priority in the overall health and well-being of people. When they go to see their GP, probably base of thumb might not be at the top of the list. I imagine as GPs, there are other things like high blood pressure and diabetes and cholesterol. But base of thumb OA can have a significant impact on occupational performance, psychological well-being and life satisfaction. Patients that we see are often preoccupied with their thumb pain because it hurts with everything they do. So from their perspective, often they're not that concerned about their blood pressure. They're more concerned about their base of thumb. Just a couple of little interesting facts about the CMC joint. It's the most important joint of the hand, plays a crucial role in positioning the thumb in space to allow for ADLs, and is integral to fine motor activities involving manipulation of small items, gripping and pinch. It's the second most common joint in the hand to develop OA. So the DIP joints of the fingers it is the most common area to develop OA. But base of thumb OA has a more significant impact on hand function than osteoarthritis in the fingers. And something that I always think about is that the compression forces at the CMC joint can be up to 12 or more times larger than the contact force applied to the thumb during tip pinch. So if you think about putting clothes on the line and using clothes pegs, if you're pinching with 1 kilo worth of force, the forces at the CMC joint can be up to 12 times greater. So pegs with 1 kilo force at the tip can create forces of 12 kilos or more at the CMC joint. So over a lifetime, the CMC joint certainly is under a lot of stress. From a functional impact point of view, it's like the patients all sort of read a page from the same book and they come in and pretty much say exactly the same things. They're having trouble turning on taps, opening jars, doing up a bra, pulling up their pants, using a phone or holding a book, personal care, walking with a walker, playing golf, opening door handles and using keys. The list goes on, and it's relatively similar with all of them. The patient characteristics that we're seeing with base of thumb osteoarthritis, you've got your typical group in their 50s and 60s who've had a gradual onset of thumb pain. The majority are postmenopausal women. It's difficult to find consensus in the literature about the prevalence. Some articles suggest that up to 33% of postmenopausal women and up to 10% of men develop CMC joint OA. But in our experience, out of every 20 patients we see, 1, maybe 2 are men. So we're certainly seeing a really high number of women who have base of thumb osteoarthritis. It's not clearly understood why more women develop it than men, but it's probably a combination of hormonal influences. The shape of the trapezium, so from my understanding in women, we have a smaller trapezium, and so the contact between the metacarpal and the trapezium is more defined rather than in men where it's a larger trapezium and more contact area. And it is related to hypermobility. So, and more women, I think, generally are hypermobile than men. And there is a genetic predisposition. So a study in 2022 did document or state that maternal hand osteoarthritis has been recognised as a risk factor for women developing hand osteoarthritis in the future. The other thing that's really interesting is that from our experience, it's primarily in the non-dominant hand. And people don't understand this. So they often come in and say, well, it can't be arthritis because I don't use this hand very much. But it's actually, from our perspective, when you do a two-handed task like opening a jar or wringing out a cloth or putting a bra on, your dominant hand is your strong, fit hand, and your non-dominant hand is your weaker hand. And so when you do a two-handed task, the non-dominant hand has to strain a little bit harder to actually match the force of the dominant hand. So over a lifetime, the non-dominant hand is working a little bit harder to do two-handed tasks. Another group of patients come in where they've had thumb pain. So not necessarily base of thumb osteoarthritis, but they've certainly got base of thumb pain resulting from trauma or from an unrelated procedure. So the most common is when someone has a fall. So when you fall on your outstretched hand with enough force to, say, fracture your scaphoid or fracture your distal radius, the base of the thumb actually, if they fall on their palm, actually takes a lot of the force with the fall. And then if the person fractures their distal radius or scaphoid and they're put into a plaster, often the CMC joint then has a secondary insult from the cast. So the joint is immobilized along with the wrist for weeks. So that can also then aggravate the base of thumb. On occasion, we see people coming in who have primary base of thumb pain, but through the assessment, we realize that it's actually a chronic UCL ligament at the MP joint. And just through changed biomechanics at the CMC joint, they end up with base of thumb pain heading towards CMC joint OA if nothing is done potentially to the UCL at the MP joint. So often these patients go on to have a repair of the UCL, which again changes the biomechanics at the CMC joint. Other injuries are Bennett's fracture or a fractured trapezium. So they may not have any sign of osteoarthritis when they have this injury, but they go on to develop osteoarthritis down the track through the trauma. And as Emily talked about, post-op carpal tunnel, so the transverse carpal ligament or the flexor retinaculum arises from the trapezium. So when that is cut with a carpal tunnel release, there is potentially a change in the biomechanics of the muscles that are attaching also around the CMC joint. Probably the other large group that we're seeing are a much younger cohort who are coming to see us with quite debilitating base of thumb pain. Again, they're mostly women in their 30s and 40s, but sometimes much younger. In this group, we're even seeing every year, we'll see probably a number of year 11 and year 12 girls who are coming to see us with base of thumb pain. They've got a combination of hypermobility and poor pencil grip, and they're having to write for 3 hours in their exams. And they're coming in with similar symptoms to older people with base of thumb pain. They don't have arthritis, but they've certainly got base of thumb pain. So the people who are hypermobile have this generalized non-syndrome related hypermobility, which is probably a normal variant in terms of people being flexible or not. So they don't have something like Ehlers-Danlos or Marfan's or other connective tissue disorders. They're just hypermobile, extra bendy. We often do a Baton's score, a scale of hypermobility, just to see where they fall in terms of what their score is. They often have this debilitating thumb pain where they are grabbing their thumb with everything they do because it feels unstable, and they rarely have changes on X-ray. So this group have altered proprioception because of excessive laxity in the joint capsule and the surrounding ligaments, and they find it more difficult to judge joint position and forces when they're pinching and using their thumb forcefully. It's hard to know where the position is and how much force to actually put through it. There was a study done just recently, 2022, published in the Journal of Clinical Rheumatology that looked at early detection of first carpometacarpal joint osteoarthritis using MRI assessment in women with high hypermobility scores. They recruited women in their 30s and 40s, I think, and it was only a small sample size of, I think, 33 women. So not a particularly robust study, but they did find that there was a significantly higher proportion of women with higher hypermobility scores that were observed on MRI to have abnormalities of both the trapezium and the metacarpal cartilage. And so their findings supported the concept that early life joint laxity may contribute to future OA predisposition. So as our population, or as the ladies that we see, mostly ladies who are maturing, their hypermobility and joint laxity decreases as they age. But it may be that when they were younger, the joints actually had subclinical injury in the younger years, which then predisposed them to developing osteoarthritis down the track. And we would certainly see a lot of people with hypermobility who are, and the two most common things we're seeing them for is base of thumb pain and wrist pain. So they would be, they make up a large proportion of our patients that we see. Just talking about the stages of CMC joint osteoarthritis. So there's a lot of high-level evidence supporting hand therapy in the conservative management of base of thumb OA. However, it does depend on the degree of osteoarthritis at the joint. There's a Eaton and Littler grading system which describes 4 stages of osteoarthritis at the base of the thumb. In the first stage, there's widening of the joint to do with, well, there's synovitis happening in the joint, and so the joint actually widens initially. In the stage 2, there's some joint narrowing. Stage 3, there's further joint narrowing and some debris around the joint and mild subluxation. And in stage 4, even actually advanced subluxation. And in stage 4, very rarely looks like this, but there's involvement of STT as well as quite advanced subluxation and joint space narrowing. So from a hand therapy perspective, we would have the most effect in the early stages. So stage 1 and stage 2. Stage 3, we sometimes can help, but stage 1 and stage 2 is really where we can make a definite change. So what does hand therapy for CMC joint OA involve? Well, as I said, it's most effective for stage 1 and stage 2. We usually only need 2 or 3 visits, and we usually space those out over 4 to 6 weeks. So we can give the patients a lot of information in that time. And really the goals of hand therapy are to help patients manage their symptoms. We also aim to improve participation in daily activities by decreasing pain while increasing stability, mobility, strength, and function of the thumb. And the other goal is to delay the need for surgical intervention for as long as we can. So hand therapy is multimodal. We provide comprehensive patient education. We're looking at models. We're talking about the joint structure. We're talking about it being a saddle joint and giving people ways to imagine what's happening in the joint. We're providing splinting. We do modalities, usually heat and massage, soft tissue mobilization, adaptive equipment prescription to protect the joints. And we provide exercises based on the dynamic stabilization program. So the goal of splinting is to increase joint stability, reduce pain and contracture, and improve function. The aim is to support the CMC joint in palmar abduction as it facilitates the inherent stability provided by the joint surfaces. So the most stable position for the CMC joint is in the C position. And so we do spend a lot of time talking about trying to maximize the time spent and the strength of the thumb in the C position. There's a multitude of different splints out there. We very rarely custom make a splint for this group. We find that custom made splints impact on function too much. So usually an off-the-shelf splint is more functionally appropriate, but sometimes we don't provide a splint. It's completely really driven by the patient. So we explain the purpose of it. And if they don't want to do it, then that's perfectly fine. But we like to show them what they should look for if down the track that they do think they need something and they can't come to a hand therapist. So the dynamic stabilization program has been described for other regions of the body, including the shoulder and knee. And over the last 20 plus years, the dynamic stabilization program for managing CMC joint osteoarthritis has grown momentum in the hand therapy domain. The aim is to achieve a stable CMC joint through web space restoration Often people get an adduction contracture where their thumb is held in against their hand. So we're looking at maintaining or restoring web space, education in stabilizing postures of the thumb, and pain-free strengthening of the CMC joint-friendly muscles. So the thenar muscles that abduct and oppose the thumb and the first dorsal interossei are the most important muscles to strengthen, because the adductor pollicis is a very strong muscle. Ooh. And we're trying to reduce the tension in adductor pollicis. We certainly don't want to do any strengthening because it's the muscle that we use all the time when we use our hand. So our thenar muscles position our thumb for function, and the adductor is the muscle that generates force. So there's 4 stages of the program. So we restore the web space, we realign the joint, we re-educate the muscles, and then we strengthen. So we can usually cover all of that in 2 to 3 appointments, usually. So we don't have success with everyone. So it does depend on symptom severity and duration, what stage of osteoarthritis they're at, treatment expectations and activity demands. So if we don't have any luck, the other options are corticosteroid injection or surgery. From our experience at Geelong Hand Therapy, post-op rehab after surgery to the base of the thumb is really challenging. I would say of all of the conditions that we see, this is probably the hardest rehab for people to manage. It's even harder than flexor tendon rehab. It can take up to 12 weeks or longer for patients to return to pain-free function. And often they're disappointed with the level of pain they have post-op and the drawn-out rehab, and often they have unrealistic expectations. But we do find clinically that the people who go on to have surgery, if they've had contact with a hand therapist prior to surgery, often they do better with their post-op rehab because they understand what's going to be happening and how long it's going to take. So even with people who have got significant base of thumb osteoarthritis, sometimes even 1 session with us prior to surgery can be beneficial. Referrals to Geelong Hand Therapy, we're available. You can refer to us via referral net or email us through or fax, or even just a phone call. So we're more than happy to take phone calls. We've got a team of 5 therapists at Geelong Hand Therapy. And if you ever want to discuss a patient or have us look at x-rays, or we're more than happy to take phone calls in the clinic at any time. So feel free to use us if you would like to. And there's my references. Okay.
Thanks, Jane. Well done.
Whereas
I can't see any questions in the Q&A. Jade, am I looking in the right area?
I think this was where the crickets happened.
Yeah, there's no
better than rats. No questions. Well, look, feel free to type questions if you like. We are most happy to field questions. In the absence of anything immediate, I noticed there's a whole group of GPs and physios, and we're really excited to have everybody. Just quickly, if you had 4 or 5 key exercises to give to a patient after hand surgery, say, or after a fractured wrist or something, like, can I ask you to pick your sort of top 5 things that we could quickly tell the patient to do while they're in a cast, for example? You know, maybe shoulder to hand or something like that.
From our perspective?
Yeah. You know, when I'm doing a ward round, what am I going to tell the patient?
Well, I mean,
I've got 10 minutes in the morning.
Yeah, if you've had hand surgery, we would be saying, make sure you reach up to the roof, reach out to the side, touch the back of your head, touch your lower back. Like, that would be a standard thing for shoulder. Takes the shoulder through a full range of motion.
And the elbow.
And then, yes,
your elbow.
Supinating your elbow, pronating and supinating your forearm. Passive flexion of the fingers is always good, especially when they're in a cast. They would probably be our go-to, I think.
Yeah, nice. And if they've conversely had shoulder surgery, like 2 of my patients today,
Yes.
you know, what are the 5 sort of, or 4 or 5 hand exercises I should be giving them in the morning when I see them tomorrow?
You go, Emily.
So we'd always be saying full finger flexion, active and passive, more passive than active. Always doing opposition, and if you can, supination, pronation of the wrist. You can get some
Okay.
flexion extension in there too, but if you just want a few key ones because you're not sure what they're going to remember, flexion
Yeah.
extension, thumb, supination, pronation.
Nice.
I just have a question. The
Lovely.
stats on CT surgery success, please discuss.
CT meaning carpal tunnel, I would assume. It's highly successful. But as Emily was pointing out, the success depends on some patient factors. So we grade carpal tunnel 1 to 3. 1 is mild, 2 is sort of numb all the time, and 3 is numb and weak. And as you might imagine, the more severe the carpal tunnel, the less likely it is to be successful. And that's how we counsel the patients. And actually, we have a model, and Emily had a lovely picture where actually we're just releasing the ligament on top. And I say to the patient, your actual nerve cells have to grow all the way from your spine, where the cell body is, down into your fingers. And that's going to take some time. And if you've damaged your carpal tunnel more, then it may only partially come back. But generally speaking, they do get some improvement, but the real question is how much. So it is generally quite a successful surgery.
I just add to that as well, Kevin, that I think from our perspective as well, the carpal tunnel release and nerve compressions are probably one of the only conditions that we encourage people to touch base with a surgeon earlier rather than later. Because I guess, there's always that perception of saying, no, you want to push out surgery for as long as possible. You want to hold off for as long as possible. But then that damage to the median nerve that can go on with a prolonged compression then affects that outcome afterwards. So
that's right. Yeah. And although the other flip side of that is, well, you're quite severe, but could I at least stop you from getting worse? And so
yes.
there's two sides to that, I guess, statistical outcome coin, depending on what you're interested in.
And the other thing is that with what Emily had talked about in terms of, my neighbour had it done and had a terrible result, so I'm not going to go and get it done. But what they don't realise, obviously, is that the thenar muscles, which are innervated by the median nerve, if they leave it too long and they atrophy, their muscles atrophy, that's much, much harder to get a good result. And so again, we'd be saying you need to go and see someone sooner rather than later to not let that happen, because once that happens, they probably won't get a fantastic result if they've got significant muscle atrophy.
Okay, Jane, did you answer that question? What is SST?
Oh, what is STT? It's scaphoid, trapezoid, trapezium. So it's arthritis between the three bone, not the carpal, not the trapezium and the metacarpal, but the scaphoid, the trapezoid, and the trapezium. So,
thank you.
You see it more on the back of the wrist rather than at the base of the thumb.
Just one more question. What percentage of patients are you performing WALAT CTR, and what are your clinical indicators for this over GA?
The short answer is I do a variation of WALANT surgery probably on everyone, but I leave it up to the patient as to which bits they want to do. So the key is the wide awake. And to be honest, if I was having surgery, I would probably not want to be wide awake. So I totally get what the patient wants. So I say to the patient, look, here are the anesthetic options. This is the surgery I do. This is the WALANT recovery that I do. So your bandage comes off the next day, you get moving, you have a shower, you can get wet. But I say, would you like to be asleep? Would you like to be completely asleep? Would you just like to be forgetful? Or would you like to be wide awake? And I even had a few patients say, can I watch the surgery? Which we can sometimes arrange on a screen, but it's a little distracting. So I usually don't do that. But, I'll hold their hand up and say, well, we're up to this bit now and, on we go. But I kind of like to concentrate on what I'm doing. But I take parts of the WALANT concept and pretty much do it on everyone. And, we do that not just for carpal tunnels, but for trigger digits and other things, because it's really shown us that a rapid recovery is helpful, and it allows the patient to do early therapy.
Thank you. Another question, can carpal tunnel surgery be done in the rooms for a private fee?
Yes. Oh, hi, Simon. Yes, certainly can. I don't personally do that, but I know several of the other surgeons in town do that. But I don't have I've never set up a facility to operate in my own office.
Okay,
Too many plants, too many bugs.
Thank you. I don't think there's any other questions, and I think we're right on time. So can I just take this opportunity to thank all our presenters this evening? What a fantastic presentation from all of you. It was really excellent. And those that were watching it, please pass on, let your colleagues know that it is on our YouTube channel. They might want to have a look at that at some stage. And please take the time to fill out our evaluation form. And pop in there if you want any other orthopaedic topics, because I'm sure we can get the speakers back to talk on some other topics for those. We do intend to run a couple more orthopaedic sessions. So thank you everyone for attending, and thanks for the presenters. Good night, everyone.
Thank you.
Thank you.